I'm Frauke Müller. I'm Professor for Gerodontology and Removable Prosthodontics at the University of Geneva in Switzerland. It was not a conscious decision to go into this area, and it's very rare as a discipline, but it somehow feels that the specialty found myself. The most rewarding is most certainly treating these elderly people, because they're very, very grateful for what we can do for them in their oral health. We are having more and more elderly people in the society, and obviously they would need some dental care. And the problems with this part of the population is that they are featured by signs of aging, but also they have a higher prevalence of chronic diseases. We need to provide the services that give access to care to these elderly populations, even if they are in an institution and not mobile enough to attend by themselves. The problem with carers in these old home institutions is that they don't have a lot of training for oral care. So we go and we train carers so they have the knowledge to perform oral hygiene measures, and they know about the risks that come with a neglected oral health. Today we know that an increased bacterial load in the oral cavity can cause aspiration pneumonia and finally the death of the resident. It is so important that these mouths are being kept clean. In principle, every person missing teeth is eligible for some tooth replacement. Removable dentures are particularly useful when many teeth have to be replaced and we have not sufficient abutment teeth for a fixed restoration. There is a whole range of parameters that have to be considered to adapt these prostheses and their design to the aged orofacial system and to the aged functioning or the functional decline of these elderly people. Treating patients with dementia or cognitive decline is a particular challenge in dental care. They would have in general more caries, more untreated caries, more periodontal disease and a poor oral hygiene than their peers of the same age who have not dementia. We have to plan with a perspective that in the last years of the disease, patients may not give access to care to the dental cavity. One of the main issues in these elderly people is a reduced neuroplasticity, so the central nervous system does less adapt to a new denture, to a new shape of denture, to a new functioning of the denture. We have a lot of help from modern CAD/CAM techniques where you can just scan an existing situation and incorporate very easily the features of this dentition or of this restoration into a new restoration. So CAD/CAM is really a fantastic novelty in geriatric care. Overdenture presents a certain number of functional advantages as they are sitting on these stable roots. These roots provide stability to the denture. They also provide tactile sensitivity because the roots still have periodontal receptors that inform the central nervous system. The bone is stimulated, bone atrophy is slowed down, the stability of the denture is better, and the chewing forces, finally the chewing performance of these dentures is also quite a bit better. Hence we try to always keep roots whenever we can in the premolar, canine or incisor areas. Dentures are made to be worn, and although they do have side effects and carry certain risks, if they're maintained well and if the oral hygiene measures are performed correctly, the risks should be really moderate. I've been to several FDI congresses. It's always very exciting, great exchange of knowledge between different countries and different cultures. I'm very excited about giving this lecture on the treatment of elderly on gerodontology because I think it's a fascinating area. With the growing population, we need to have more people interested in this domain. So the platform of the ATI with a huge number of participants is ideal to promote oral health for the elderly patients and interest colleagues all over the world to get involved, to acquire the knowledge and then perform oral health care for the elderly population.